The following podcast is part of a certified educational activity titled Innovative Treatments for Bladder Cancer, Thoughts from the Chair. Access the entire activity and complete the post-test at peerview.com/YFM860. Downloadable slides and practice aids are also available.
Welcome. My name is Arjun Blar, and I'm the director of the GU Medical Oncology Program at the NYU Langone Health Laura and Isaac Perlmutter Cancer Center, and I'll be talking about innovative treatments for bladder cancer. And really what we're going to be focusing on over the next 30 minutes are some top-line, high-level data of novel therapies and approaches that were highlighted at the ASCO 2020 virtual meeting. So whenever we talk about advanced bladder cancer or any bladder cancer disease state, it's always important to put things into context. Non-muscle invasive bladder cancer and muscle invasive bladder cancer are treated with TURBT and intravesical therapy or radical cystectomy and chemoradiation respectively, and it is for curative intent. And these are the standard of care that's been around for years. In advanced disease, whether it's in the first line or the second line setting, treatment is geared toward palliation and an extension of survival. We have novel therapies that have been tested and recently approved in all of the disease settings, and it's really exciting to discuss some of those data and highlights with you today. So to set the stage for metastatic bladder cancer, let's talk about some of the newer approvals that have happened over the last couple of years. In 2017, both atezolizumab and pembrolizumab was approved for the first-line treatment of advanced bladder cancer patients who are cisplatin ineligible. The atezolizumab study looked at 119 patients as part of cohort 1 of Vigor 210 and found a 24% objective response rate and a long-term survival of 41% at 2 years, which is quite exciting. And in pembrolizumab, similar study, 29% objective response rate. In the PD-L1 overexpressors, it was a 47% response rate and a median survival of 18.5 months. And what these data highlight is that a significant proportion of patients who are untreated with metastatic bladder cancer can have very durable responses to monotherapy checkpoint blockade, and that can translate to extended survival. And what you see with some of the survival curves, in particular for KEYNOTE-52, is that there's a plateau to this curve, which means that there are patients who are alive and doing well many years after starting treatment, and it's potential that we may have induced durable remissions, and potentially even complete remissions in these patients that could be long-term and certainly may translate to cures. In August of 2018, there was a very important update to the FDA label for both atezo and pembro. And this label change really highlighted that patients who have low PD-L1 expression actually may not fare so well with checkpoint blockade as the first treatment. The reason these label changes happened was that interim safety analysis from two very important phase 3 trials, in Vigor 130 and also KEYNOTE-361, found that patients who were randomized to the experimental arm of immunotherapy alone, who had low levels of PD-L1 expression, these patients actually had worse survival when compared to chemotherapy. And what that did is prompt the label change in August of 2018. And now for both pembro and atezo in the first line setting, patients who are cisplatin ineligible and also have high levels of PD-L1 expression are candidates for treatment, but it also preserves access to patients where any platinum-based chemotherapy, including carboplatin, is not an option. And for these patients, it's either best supportive care or checkpoint blockade, and so it preserves access for these patients. Let's talk about some of the more recent advancements, beginning with antibody drug conjugates. Well, what are antibody drug conjugates? These are essentially antibodies that are antigen-specific and target a membrane-specific receptor, and they're conjugated to a payload, which is usually a highly potent cytotoxic molecule. And together, what this basically agent does is deliver a very highly potent cytotoxic agent directly to the cancer cell. One of the agents in this class that has had the furthest along in development is enfortumab vedotin. The target is Nectin-4, which is highly overexpressed in bladder cancer, and the payload is a novel microtubule disrupting agent called monomethyl auristatin E. In the phase 2 pivotal study, EV201, what we found was that 44% of patients responded, 84% of patients had at least some measure of disease shrinkage and durability to this, and so that ultimately led to accelerated approval in December of 2019 in patients with metastatic bladder cancer who had progressed after platinum-based chemotherapy and immunotherapy. And so that was an approval. At ASCO 2020, updated data from a very provocative study of enfortumab vedotin in combination with pembrolizumab as very first-line treatment even showed even more exciting results. What we found in this 45-patient trial of patients receiving enfortumab vedotin along with pembrolizumab as the first treatment, that 73% of patients achieved an objective response, about 93% of patients had at least some measure of disease shrinkage. And what's particularly exciting is the durability of responses. The median duration of response for those 73% has still not yet been reached with a follow-up of roughly 2 years. And what's particularly exciting about this approach is that ultimately it proves that potentially there's synergy, immune synergy between enfortumab vedotin and pembrolizumab. And that has led to a couple of phase 3 trials. One is a phase 3 study, which is EV302, and then also a randomized study is within the context of EV103 that is testing enfortumab vedotin plus pembrolizumab. What about other combination studies? Vigor 130 is an important study that highlights the combination of chemotherapy plus immunotherapy versus chemo alone. This data was actually initially presented at ESMO 2019, but certainly serves mention today. The primary endpoint of this trial was to compare both progression-free survival and overall survival for chemo plus immunotherapy versus chemo alone. And at the first interim analysis, they found a benefit in terms of PFS that was statistically significant. And this is Arm A versus Arm C. Arm A is the chemo plus IO arm. Arm C is chemo alone. And if you look at the survival curves, there's a suggestion that there's a benefit. It did not meet the protocol's pre-specified efficacy boundaries to determine statistical significance. But certainly there's a suggestion that the combination can extend survival. I think most of us in the field were a little underwhelmed by this data. We were hoping for a much, much larger benefit in terms of survival, but obviously we will need to follow these data closely and until they're mature. The subgroup analysis, in my opinion, is probably the most important aspect of this trial, and I'd want to focus on both the PD-L1 negative patients as well as the PD-L1 positives. The PD-L1 negative patients who were treated with immunotherapy versus chemotherapy, you can see that there's a sudden drop in the survival curve for patients who were treated with atezo monotherapy in PD-L1 low expressing patients. In these patients, this drop in the survival curve is what prompted the label change in August of 2018. I think it's an important consideration and highlights that the very first choice that you make for a patient in the first line setting, you have to be really careful about this, and PD-L1 negative patients probably should receive chemo first. However, the PD-L1 positive patients, you can see the survival curves actually separate and actually favor immunotherapy both early on and also over time, suggesting that for PD-L1 positive patients, that immunotherapy alone could be a very good treatment option as opposed to platinum-based chemotherapy. And so the take-home messages here, number one, checkpoint blockade plus enfortumab improves responses as well as potentially durability of responses in a single-arm study. I think it's poised to potentially change how we treat bladder cancer completely. Chemotherapy plus immunotherapy, I think a little bit underwhelming as an approach. However, subgroup analysis of PD-L1 positive patients tells us that there is at least some patients who benefit from first-line immuno. Keynote 361, there was a press release just a couple of short days ago that showed that study was also negative for both PFS and OS. So I think really moving forward, chemo plus IO is not an all-comer approach for patients with advanced bladder cancer. Perhaps sequencing is the right way to go. And so on the subject of sequencing, a very important study called Javelin 100 was presented at the ASCO plenary session just a couple of short weeks ago. And the premise of this study was to really test maintenance immunotherapy after chemotherapy. So it's not really a first-line trial, but it's a kind of a early second line is probably the best way to describe it. So all patients in this particular study had previously received chemotherapy as their very first treatment for metastatic bladder cancer. That was investigator choice. It's a decision that had already been made even well before the patient was even approached about the study. And then for patients who achieved a stable disease outcome or better, were then approached about this study, consented, screened, and randomized to either maintenance immunotherapy with avelumab or best supportive care alone. No placebo control and no crossover was allowed as part of the study. the fundamental question is treatment now versus treatment later, because we know that at the time of progression, immunotherapy is the standard of care. And so that's the premise behind which this study was conducted. The primary analysis showed a benefit in terms of overall survival. The curves separate and they maintain separation. The hazard ratio is quite promising at 0.69, favoring avelumab. And what you can see here is the suggestion that for patients who received first-line chemotherapy, immunotherapy as maintenance should be a standard of care. If you look at even the PD-L1 subgroup positive patients, these patients perhaps benefited even more. And that's not surprising because we know that there is in general a trend toward improved outcomes for PD-L1 positive patients treated with immunotherapy because they're more likely to respond to treatment. Adverse events, nothing unexpected. It's the safety that we typically see with single-agent checkpoint blockade, which is encouraging. So I think that's a really important study. I will say, though, that, again, the rate of crossover was about 40% in the patients. I would argue that it probably should have been a bit higher because all of the patients who came into the study all had stable disease or better, so they all had controlled disease going into the trial, which means at the time of progression, I think more than 40% of patients should have had access to second-line checkpoint blockade as a standard of care. However, all that being said, though, is still a decent amount of crossover, and the study did meet its primary endpoint. Let's pivot now to targeted therapy. FGFR targeted therapy, a very important a class of agents that we've been testing for years in bladder cancer, going more than a decade or more. We're better now at identifying the driver alterations using next-generation sequencing, and I do believe that our drugs are a bit better. Multiple lines of evidence tell us that somewhere between 15 to 20% of patients have somatic alterations in DNA, specifically involving FGFR genes, and those driver alterations make targeting this pathway important. The BLC 2001 study tested erdafitinib. It was a single-arm dose escalation, dose expansion study. It ultimately settled on erdafitinib 8 milligrams once a day with up titration to 9 milligrams a day based on phosphate levels, and pre-selected patients with advanced bladder cancer who had FGFR2 translocations or FGFR3 translocations or FGFR3 activating mutations. So if you had one of those three, you were eligible for this study and then potentially treated with erdafitinib. The data are quite promising, 40% objective response rate. The swim lane plots suggest some durability to this, at least for a subset of patients who have remained on treatment for quite some time. And the survival curves are encouraging. And I think the challenge with any phase 1, phase 2 study, single arm, is that the survival curves are often influenced by the protoplasm of the patients who were selected. But it is nice to see that the patients who are enrolling in trials, there's clearly a plateau of patients who are surviving many years with advanced bladder cancer. And it really highlights that we're making progress in the field. Central serous retinopathy is a known toxicity of FGFR targeted therapies. It's a class effect. We see it. There was an update to some of the safety regarding that at ASCO 2020. The takeaway here is that when it does happen, it tends to happen early, and that over time, patients if they're going to develop it, they develop it early, and if they haven't developed it within 2 or 3 months of having started treatment, it's unlikely they're going to develop it later on. So it tells us how to kind of expect these toxicities. Importantly, all patients should have a baseline ophthalmologic exam, and on treatment, certainly for cause, if they have developed blurry vision, they should see an ophthalmologist. If ultimately they're diagnosed with CSR, holding the drug generally leads to a complete reversal of the toxicity. So what are the summary points about frontline bladder cancer and FGFR targeted therapy? Number one, maintenance therapy with Javelin 100 seems to improve survival. That, along with the data from Vigor 130, as well as the press release from Keynote 361, taken together tell us that sequencing is the right way to go with metastatic bladder cancer. Chemo plus IO as a first-line combination is probably not the answer from an all-comers approach. So I think that this is potentially practice-changing. Erdafitinib, well established now, since their initial approval in April of 2019. FGFR targeted therapies clearly have a space in advanced bladder cancer. I think what we will learn is that the selected mutations may not be the whole picture. There are other alterations involving the FGF pathway, including both ligand amplification, receptor amplification, even in the context of a wild-type receptor gene. These patients may also have drivers, may also be oncogenically addicted to FGFR, and therefore potentially responsive to FGFR targeted therapy. All right, what about in the localized setting, neoadjuvant, adjuvant therapy, how are we treating this disease? So a lot of evidence has been generated over the last several years looking at immunotherapy in the neoadjuvant setting. There was the PURO-1 study, which looked at pembrolizumab alone, Abacus study, which looked at atezolizumab alone, and then more recently an HCRN study led by Chris Holmes that looked at chemotherapy plus immunotherapy together. All of these trials have told us that the addition of immunotherapy to chemotherapy or immunotherapy on its own leads to pathologic complete responses in the bladder when they're given to patients as in the neoadjuvant setting before cystectomy. And we've always been using the neoadjuvant approach in muscle-invasive bladder cancer for years, and so this lends even more evidence to it. One important study that I think it's important to highlight was the Nabucco study, which looked at neoadjuvant ipilimumab and nivolumab in stage 3 bladder cancer patients. They initially underwent IPI at 3 mg per kg, followed by IPI-NIVO, and then ultimately underwent a cystectomy. And what you see is encouraging pathologic complete response rates, even in patients who are PD-L1 negative, with the addition of CTLA-4 blockade with ipilimumab and nivolumab. Obviously, this is a small study, needs to be tested in a larger setting, in a randomized setting. Checkmate 901, importantly, is a randomized study involving IPI-NIVO as first-line treatment in metastatic bladder cancer, and it's a phase 3 trial. So that, plus this trial and many others, are really asking the question, does CTLA-4 add to checkpoint blockade with PD-1 alone in this disease? A number of other ongoing studies are important to highlight. The Niagara study, the Energize study, Keynote 905. All of these are variations on a theme, neoadjuvant immunotherapy prior to cystectomy. The major difference here is that Keynote 905 is looking at immunotherapy alone in cis-ineligible patients. We know that the standard of care for these patients is definitive local therapy alone. There is no neoadjuvant treatment outside of cisplatin, so I think it's an important advancement if ultimately this trial proves to be positive. What about adjuvant? A number of other trials similarly designed. Again, the main theme is patients who've had a cystectomy for high-risk disease. The standard of care is no adjuvant treatment, so patients are here in these adjuvant trials randomized to immunotherapy versus observation. The studies that are ongoing include in Vigor 10, Checkmate 274, as well as the Ambassador study. The in Vigor 10 study was presented at ASCO, and I think we should take a few minutes to highlight the data from this trial because unfortunately there's some very sobering data from this particular study. So the primary endpoint of this trial was disease-free survival in high-risk patients who have undergone either cystectomy or nephroureterectomy for high-risk muscle-invasive urothelial cancer. And in the intent-to-treat analysis, there was no benefit in terms of disease-free survival. And similarly, when you looked at the PD-L1 expression scores and high PD-L1 expressors, there was still no benefit. In fact, whatever separation we saw from the intent-to-treat group was virtually lost altogether in the PD-L1 positive group. And also what we learned is that in this adjuvant trial, and confirms what we had seen before, is that the IC23 biomarker using the SP142 assay is prognostic for better outcomes. So if you looked at just the IC23 patients, they actually had a better prognosis following cystectomy compared to patients who are PD-L1 low or non-expressors. So I'm going to pivot really quick to talk about novel advancements in muscle-invasive bladder cancer, specifically with regard to alternatives to cystectomy. Tri-modality bladder preservation is an important standard of care that patients should have access to. It involves a maximal transurethral resection followed by chemotherapy and radiation. You put those three together, you get tri-modality. And when you look at risk-matched patients from a high-volume center, this is data from the Princess Margaret, is that when you match these patients, the outcomes from cystectomy versus trimodality therapy are virtually identical. And it tells us that maybe we should be counseling our patients about this option. Unfortunately, randomized data to compare cystectomy versus chemoradiation, unfortunately, will likely never occur, but it's important to understand that this is an acceptable and standard option for patients who don't want a cystectomy. So what about immunotherapy being added to trimodal therapy? Well, basically what we're asking is that chemoradiation, can we add immunotherapy to it? We have a precedence. The Pacific study looked at stage 3 non-small cell lung cancer patients who were treated with definitive chemoradiation, and they were randomized to either adjuvant durvalumab versus observation alone. And in this particular study, they extended disease-free survival or progression-free survival as well as overall survival. So we have some evidence to back this up. How does radiation actually impact on immune responses? Radiation actually may help us convert cold tumors to more so-called hot tumors, which means more inflamed, usually by inducing immunogenic cell death, release of tumor neoantigens, enhancing T cell priming, and getting more T cells to traffic into the lymph node that then, into the tumors, which can then hopefully lead to augmented immune responses. So a couple of very important studies that are currently ongoing, and we had trials in progress posters at ASCO, SWOG 1806 as well as Keynote 992. Very similar in that they're adding immunotherapy to trimodality bladder preservation, some subtleties in terms of trial designs and the way the treatment's given and radiation schedules and chemotherapy schedules and so forth. But ultimately the broader question is that can we offer bladder preserving therapy to patients with muscle invasive bladder cancer and still have curative outcomes? So when we put this all together, we have neoadjuvant, adjuvant trials of immunotherapy ongoing. The adjuvant trials, so far been reported as in Vigor 10, very underwhelming, and I think it's one of the most disappointing trials that we've seen so far because there's really not much way to look at it. Adjuvant immunotherapy doesn't seem to do much, which is unfortunate. But the other studies of neoadjuvant and definitive chemoradiation with immunotherapy, these are still ongoing and could still lead to better outcomes. I'm going to close finally with some advancements that we're making in non-muscle invasive disease, beginning with pembrolizumab in Keynote 57. A little bit of quick background: high risk non-muscle invasive bladder cancer are patients with basically high-grade disease. Standard of care is intravesical BCG. For patients who are BCG unresponsive, the standard of care is cystectomy. I think I've already mentioned it. Patients don't want a cystectomy. It's a morbid procedure, about 4 to 5% mortality rate, highly curative, highly curative, but obviously it can have major consequences for the patient, not only in morbidity, but also long-term quality of life. And so it was in this context that this study and many others are looking for options to treat non-muscle invasive bladder cancer that avoid cystectomy. Keynote 57 was a single-arm study that looked at 2 cohorts of patients, Cohort A, which was the carcinoma in situ population, Cohort B, which is the papillary disease-only population. Cohort A, which was submitted to the FDA and was the subject of the FDA approval in January of this year, aimed to enroll about 130 patients with BCG unresponsive, high-risk carcinoma in situ with or without papillary disease. And the ultimate outcomes measures that we were looking for were complete response rates. So ultimately, the data was submitted to the FDA was efficacy evaluable population of 96 patients. In that population, 40% of patients achieved a complete response at the 3-month cystoscopy. So we know we can get rid of the carcinoma in situ in 40% of patients, even just after 3 months of treatment. The FDA said that at 3 months was kind of a hard stop. This trial was a bit ahead of its time. It was first designed in, I think, 2013. So patients could not be treated beyond progression or beyond persistence of CIS. That's one limitation of the study. But even then, for the patients who were allowed to continue on past 3 months, of those patients, about half of them had durable responses lasting beyond a year. And if you look at this DOR curve, it'll tell you a little sense of how durable these responses are. So if the patient's lucky enough to have achieved a complete response to pembrolizumab, half of those are lasting beyond a year. And at the last data cutoff, 17 patients are still in a complete response, and this is lasting 2 years or greater. And so that's really important to understand, is that checkpoint blockade is active in localized non-muscle invasive bladder cancer and can potentially save the bladders of these patients for a long period of time. Safety, very similar, if not identical, to what we know about pembrolizumab. Nothing exciting here in terms of new outcomes. One of the questions we often get asked is that for patients who did not respond or responded initially and then progressed, what's happening to these patients? So we looked at that, and this was an important consideration, and we included this in our ASCO presentation, is that 36 patients ultimately chose to get a cystectomy at some point in their care. Most of them much later on, because obviously the whole reason they went into this study was they didn't want a cystectomy. In fact, 91% of the patients enrolled in this trial enrolled because they refused cystectomy. Of those, again, so 36 patients, selected subgroup underwent a cystectomy. Only 3 actually had pathologic upstaging, which is actually probably under the estimate. So we usually see up to 20% of patients have upstaging of their disease once their bladder is removed. So this is quite encouraging, suggesting that even in patients who don't respond in the bladder per se, they may actually have some regression in their disease because of the systemic immune activation that we generate. So thanks for joining me today. I've covered a lot of different areas of progress that we're making in bladder cancer in terms of novel therapies, antibody drug conjugates, immunotherapy, chemotherapy, intravesical therapies, gene therapies. And so what this highlights is that we're making a lot of progress to make up actually for years of lack of progress in the past. And ultimately, I think that the data we've shared today is going to demonstrate that we are actually improving outcomes for patients with bladder cancer. So thanks for joining me today.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/YFM860. This activity is supported by educational grants from Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Merck & Company Incorporated. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.